Um, Hello and welcome to the Breast Grand Rounds. My name's Fiona Heggie. I'm a radiation oncologist and I work at Peter Mac, and it's my great pleasure today to be chairing this meeting. Before we commence, I would like to do an acknowledgement of country. I would like to acknowledge the traditional custodians of the lands on which myself and today's presenter and audience are located. I would also like to pay respect to elders both past and present and extend that respect to other Indigenous Australians present online. Before we kick off today's program, there are a few housekeeping notes. The first thing to note is that today's event is being recorded and it will be available on the VCCC Alliance Open Learning page. And there you can also find recordings of other previous webinars. If you have any questions for today's presenters, you can do this via the Zoom Q&A function or chat function, which should both be on the toolbar at the bottom of your screen. Please submit your questions throughout the presentation, and we will aim to answer your questions at the end of the session. Now, it's my very great pleasure to introduce Dr. Claire Phillips. Claire is the Acting Director of Radiation Oncology at Peter Mac, and she has 20 years of experience treating breast cancer and brain tumors. She has led clinical trials in brain metastases, glioblastoma, and uveal melanoma, and headed up the team that brought the Gamma Knife to Peter Mac in 2020. Claire is very excited to have recently joined the steering committee of the Caries Beanie for Brain Cancer Foundation Brain POP Initiative, and she's going to speak to us today about the management of intracranial disease in breast cancer patients. So I'll hand you over to Claire. Thank you.
Mute. Just trying to get my presentation. Here we go. Here's the presentation that we want. I'm assuming you're seeing my presentation and I'll get started. So thanks for the introduction, Fiona. It's always my pleasure to come to the Grand Round. It's a while since I've been with the breast cancer group, who I missed somewhat since I had to leave you in February. So I was asked to talk about brain metastases and also to give a bit of an explanation about the Gamma Knife, which is something people have heard us talking about in the last 6 months or so here at Peter Mac, probably a year now. It's something that perhaps a lot of people don't really know what it is. So it's an opportunity to explain that to you all. So I've called my topic multidisciplinary care of brain metastases so complex it makes my head hurt, and it is becoming increasingly complex and multidisciplinary, and I'll try to demonstrate that today. So what? Let's just set the talk overview will be I'll set the scene a little bit about the brain metastases issues, as mentioned, explain more detail about what the Gamma Knife is and how we use it. And then consider what are the changing roles of the different treatment modalities that we have available for brain metastases, and just talk about a few particularly hot topics that I see in brain metastasis management at present, in particular role of radiosurgery integrated with active systemic therapies and pre-op cavity radiosurgery. So why do we treat brain metastases? Well, if I was giving this talk 20 years ago, I'd say we're treating the brain metastases because we don't want the patient to die. And we learned through the 1980s that if you irradiate brain metastases with whole brain, then the patient's got about double the median survival compared with not actively treating with some sort of anti-cancer therapy. So that underpins the intent. And of course, brain metastases can be very dangerous. But as we've moved into the 20th century, it's become rather more complicated because we detect a lot of asymptomatic small metastases, as well as having patients present with nasty life-threatening disease. And so I think about the different roles, the different things we're doing when we talk about brain metastasis management. Clearly, there's a role for surgery to help us make a diagnosis, perhaps. Lung cancer patients often present with unknown cancer and a big lesion in their brain with a seizure or something similar. We might be wanting to update the phenotype, a common thing in breast cancer. Obviously, we're trying to maintain quality of life, palliate symptoms. There's a range of ways that we might do that. Corticosteroids can do it very quickly. In BRAF mutant melanoma, BRAF inhibitor, so BRAF-MYC combination can have incredibly quick disease response and palliation of symptoms. That's a fairly unique situation, I suppose, but it's become a common step that we could take. And then the workhorses perhaps remain radiation and surgery. with surgery particularly important when you've got a very large mass causing a threat to life and major symptoms such as seizure, vomiting, etc. And then one of the things that I think we do a lot of with radiosurgery is try to protect the patient from neurologic deficit and deterioration of quality of life from disease progression in the brain. So again, a bit of the big picture stuff about brain metastases. There really are increasingly prevalent and complex issues around brain metastasis management. We see a wider range of diseases than we ever used to see: GI tumours, gynae tumours, prostate cancer, sarcoma. They've become something that we just see rather than very, very rarely or almost never seen. Patients are increasingly living for a long time with brain metastases. As mentioned, they might be symptomatic, but they're often asymptomatic, so we don't want to worsen their quality of life. And then there are all these competing issues about what's the main driver for their care at the moment. And although it is slowly changing, there's still not great literature about how to integrate therapies and what are the expected, what's the best way to make use of our different active therapies. Things are a lot better than they used to be, as I've mentioned. In particular, accessing neurosurgery and radiosurgery, patients don't have to have excellent performance status to be able to tolerate those treatments now, and those treatments are much more flexible and can be used much more quickly than they used to be able to. There's this whole gamut of active systemic therapies I'll talk a bit more about later. And so, as probably most of the audience is aware, we've had multidisciplinary meetings specifically about brain metastatic disease for some time now, and I'm just going to give some examples about why we find those very useful. So an example about making good use of surgery. So this top patient, an operation is a good idea, it's indicated. It's a breast cancer patient by chance, she had a big mass, causing mass effect, risk of obstruction entirely of the fourth ventricle, which is not very good for you, risk of coning, and presented with quite profound posterior fossa symptoms. She has mass effect, and in particular mass effect in the posterior fossa is a dangerous thing. The lesion's not cystic, so it's relatively straightforward for a surgeon to remove that. They like removing big solid things. And it doesn't have a meningeal base, so the risk of leaving disease along the meninges or seeding along the meninges is relatively low. And in addition, we knew she had HER2-positive breast cancer, so she had good disease control. She was otherwise well. There was good reason to protect this woman from any neurologic death. But on the other hand, just recently we've had this lady who's got triple-negative breast cancer, and she's got a big tumour, so often we think about surgery for big tumours. But the reasons why we didn't think surgery was a good idea as a first step for this patient were a few. First of all, it's in the frontal lobe without much mass effect, so it's quite safe to just watch her for a little bit. It's not an emergency to have an operation. It's a very cystic lesion, so the risk of spilling tumour intraoperatively is extremely high, and it's very, very hard for the surgeon to remove that properly because it doesn't really have substance that makes it easy for them to know where the tumour stops and the brain begins. And it's also got a big meningeal base. You can see it wrapping around the orbit here. Very high risk for seeding and leaving disease behind at the operation. Finally, it's triple-negative breast cancer. And whilst I'm not sure that there's great publications about this, there's no doubt in my mind that triple-negative breast cancer regularly recurs within 3 months of craniotomy. So it's not a great treatment for triple-negative breast cancer. Making good use of whole brain radiation. So whilst I said we don't use whole brain as much as we used to, it still is needed if we've got leptomeningeal disease, if we have miliary disease, lots and lots of little tiny brain metastases everywhere. And increasingly we might use it to support a change to a new systemic therapy, with BRAF to immunotherapy being the most extreme example in melanoma. And I've explained before, whole brain's useful. We can do it more than once, but we can't do it over and over and over again. So you want to make sure that the timing of when you give it is appropriate. And the acute toxicity is quite significant. In the elderly, fatigue is very profound. Even for younger patients, they can be very tired and they can get a lot of nausea and vomiting. People worry a lot about the late effects, and I will show you an example of bad late effects in a minute. But in practice, for the patients who really need whole brain, they really need whole brain, and this is a lesser issue than the acute toxicity and the timing of it. This is just an example of somebody's brain that really couldn't be treated with anything but. So here's an example of another lady who couldn't be treated with anything but. She's also on the ward at the moment, and unfortunately I call this a Pyrrhic victory because she's really now suffering the consequences of 2 years down the track, having had a huge amount of brain disease that she presented with, controlled well by a combination of whole brain radiosurgery, and has now got morbidity from that. So she presented, as you can see, whilst these lesions were large, they weren't amenable to resection because of the eloquence of the brain here. So she had to have whole brain radiation. 2 months later, she had a very dramatic response, but she still had residual disease. And we had decided that we should give these radiosurgery boosts. We weren't a little bit anxious about it because the corpus callosum we see more and more is quite sensitive to radiosurgery in terms of causing radionecrosis, and that's exactly what we did. And she's had a problem of recurrent radionecrosis here since about a year after she had the whole brain. So a year from, that was 2 years ago she had the whole brain, a year ago she had radionecrosis, which we actually ended up treating with bevacizumab, which is an emerging practice. Now, you can see here her temporal lobes used to be quite healthy. She had quite a young looking brain. Now she has a very old, beaten up looking brain. And there's no doubt that the whole brain radiation has contributed to that. I have plenty of other patients who haven't had such a profound effect from the whole brain, so it's more complicated than just the treatment, but this is an example of how the sort of effects can be. So then thinking about how we can make good use of radiosurgery. So this is a case of one of these melanoma patients who was transitioning from BRAF inhibitor to immunotherapy, and she'd been on that for a while. Then in March of this year, she turned up after having been found on the middle of the highway, actually, in status epilepticus as she tried to cross the road to her friends. And she had 5 lesions, a couple of which were quite problematic. The temporal one, which had caused seizure, as you can see here, and one in her pons, which obviously if it grew quickly could be very life-threatening. So we talked about her in the MDM and agreed that what we would do would be treat these 2 most dangerous ones as soon as possible and then get her onto immunotherapy, and she stayed on a low dose of the BRAF inhibitor until she'd been transitioned. Now, the good thing about the gamma knife, which I'm going to tell you about in a minute, is that we were able to get this treatment started and get her off steroids in a very short space of time, which facilitated this coordination of care. So just a bit now about the gamma knife. So you might recall this picture from the last time I spoke about brain metastases. There are sort of 3 broad families of treatment modalities. So this is the tool that we've got now, which is called the gamma knife, and uses radiation sources that are built into the machine. This is a modified linear accelerator, just like our other radiation machines, which treats the patient using specialised equipment for accuracy and complexity. And the cyber knife, this is actually a little linear accelerator on a robotic arm, which also has great flexibility for field positioning and is used not just for the brain, but also for the body. As I should mention, the stereotactic linear here is. So the gamma knife, why did we want the gamma knife, or what is it special about it? So it's incredibly precise. Because of the way that it's designed, it has much less inaccuracy, well, much less range of movement and variability about position. And in the end, that gives us greater accuracy. So the way that it works is inside this head here are 192 little radioactive sources made of cobalt, which has been bombarded to be radioactive. They're quite close to the patient's head, so the beam can't diverge as far. And the radiation energy is lower than in the linear accelerator or in the cyber knife, which is good in the sense that the radiation doesn't penetrate as deeply into the body. And in the head, that doesn't matter because it's not a very big structure. As mentioned, it's been around for a long time. I'll show you some pictures in a minute, actually, of that. And when this mask opportunity was added to what used to be only a frame, it made it very flexible in the cancer setting, and so that's why we thought it would be good for us. This is what the frame has looked like until now. We've just received delivery of these new frames, which you can see are much more streamlined. They're lighter and easier to use and a bit less MR interference. So just to summarise some of the other differences, the linear accelerator can treat anywhere in the body, which is useful in a radiation department, of course, because you've got other things that you want to do stereotactic treatment to, SABR, as we call it by nickname. But with the rising caseload in brain radiosurgery, we needed another tool. The mask meant that this was a very appealing tool. It does things that a linear accelerator can't do at a technical level about dose, tiny dose around important structures. And one of the downsides of it, though, is it's radioactive. And the activity falls over time. So when we first got it, it was quicker to treat patients than it is now. And by about 5 years down the track, it'll take twice as long to deliver the same amount of radiation. And eventually that becomes unworkable and you have to replace the sources, which takes about a week. So this is a bit of a history of gamma knife. First time it was clinical was back in the 1960s, 68 in fact. The headpiece thing used to be more like you're at the hairdresser. Now it's a rather more sophisticated thing with 5 panels of sources, and they're all on what's called a sector, and the sectors can move in and out to line up the sector over the size of the collimation that you want, which might be 4 millimeters, 8 millimeters, or 16 millimeters, or it might be blocked. And that gives, it sounds complicated, but it actually gives an amazingly simple way of building a radiation plan, which I'll show you in a minute. It's not as elegant when all the casing is off. This is 18 tonne of steel to provide the radiation protection. You can see here the sources, how they go in and out from the back of the machine. Here is one of our radiation therapists who was pregnant at the time, and she's able to stand right up against it. These are the measurements done by our radiation protection officer when we receive the machine to demonstrate what sort of exposure to radiation there is. You can see here there's about 0.1 microsievert per hour, but in fact, a year's dose of radiation is in the order of 1,000 microsieverts. So you can see it's very, very safe. The way that we monitor the position of the patient when they're undergoing treatment, it uses this infrared system that looks at a dot on the patient's nose and also beside the patient's head. And then we get real-time positioning information about how their heads might be moving or not moving. And if the patient starts to get out of what we call tolerance, we can talk to them or sometimes wake them up because they've fallen asleep and they're snoring, and that's the problem, to give us generally between 0 and 0.5 millimetre movement of the nose, which translates to almost no movement at all at the base of skull. So just a few pictures here. This picture here is from our linear accelerator that used to be our bread and butter for brain metastases. And you can see these big arcs that demonstrate that the machine is moving around the patient, always aiming at the metastasis as a way of getting the radiation in. And you can get, nice tight fields, but as I mentioned before, there is a bit more divergence. So in certain situations, it just can't be as tight as the gamma knife is. For the gamma knife, the plan starts with just one what we call shot, and here's an example of just one red dot, and the dose being just, well, actually 2 there now. The dose is built by adding 1, 2, and then you add another 1, and you can see that the yellow line gets stretched down and the dose goes a little bit further, and then you want to get it a bit wider, so you put on more red dots, and it's a bit like painting a picture. So it's a very different way of thinking about how we build the radiation dose, but it can give great refinement around complex shapes. We can even rotate the system within the patient's head, which is what this is demonstrating here. Not within the head, within the machine around the head. So the common indications for using the gamma knife brain metastases, at least 50, if not 60% of our workload is brain metastases in this institution. Some hospitals, very much a gamma knife is connected to a radiosurgery department, to a neurosurgery department, and they'll treat much more of this benign base of skull disease, which is the long-standing experience with gamma knife treating all of these. Arteriovenous malformations was one of the first things that was treated with a gamma knife, which is a developmental abnormality of blood vessels that can bleed and cause seizures. And an area that we're very interested in, but COVID has rather impaired our ability to develop a new program, is functional radiosurgery. Again, one of the first reasons why gamma knife was designed back in the 40s were the ideas, the 60s, to use clinically by neurosurgeons wanting to treat things that they couldn't access safely with surgical procedures. Trigeminal neuralgia is a terrible pain disorder that radiosurgery is one tool you can use to treat. Here's just an example of how tight the plans can be. This patient has, it's called a vestibular schwannoma, sort of a long little skinny tumour here, pretty tiny, as you can see. The scale here gives you an idea. This is 1 gray within about 1 centimetre or 1.5 centimetres of the tumour. And the dose of 4.5, we're trying to keep off this blue structure, which is the cochlea, and the gamma knife allows us to do something that a LINAC just wouldn't be able to do. That's why it's become a very useful tool for us. So getting back to brain metastases, another thing that perhaps we didn't appreciate as well before we had the gamma knife as we do now is just what a fantastic tool it is for regional patients who can come either the night before, or if they're up for an early morning drive, as some of them are, the same day, have a planning MRI. We do need to have an MRI QA'd specifically for distortion, so that we know that it's incredibly spatially accurate for the gamma knife treatment. So they have a special MR, which only takes 10 minutes if they've had a recent diagnostic one. We make them a mask on the gamma knife itself and do a cone beam CT. So I forgot to show you that this arm here on the side of the machine, wherever I am here, this thing is a cone beam CT, which is used for the simulation of the treatment. You don't have to have a separate scan on a CT scanner as we do with the linear accelerator, at least not for brain metastasis treatment. And then the very same day, the lady on the ward was a good example. She had a lesion in her pons and a second lesion. We were able to start her treatment on the same day as her measurements. And so if you're a patient from the country, that provides an amazing flexibility to get everything done despite having to travel from home. And we can even do that for really quite complicated treatments. So even well over 5 lesions, which with a linear accelerator might take us several days to get planned and quality assurance done. Here's an example of a patient who, I won't go through the background history, but had whole brain radiation before. In fact, and had 16 little baby lesions and was able to have the treatment over 3 sessions. You can see the times are relatively slow, but in fact, if we treated this number of lesions on a linear accelerator, because of the complexity around setup and delivery, you start to have a treatment time that's also extremely long once you get onto multiple lesions. And in fact, treating 16 lesions, if you did that on the linear accelerator, would probably take you a similar time. So just getting back now to big picture around how we think about brain metastasis treatment. Back in the 90s, certainly till well into the first decade of the 2000s, whole brain was really the workhorse of brain metastasis treatment. There was a growing role for radiosurgery, but literature was very restricted to this idea of how many lesions was it appropriate or safe to treat with radiosurgery, and the randomized studies had used a number of 1 to 4. And surgery was essentially being used for solitary lesions and then being followed by whole brain. And systemic therapy, which was mostly just chemotherapy, really had a very tiny role. But if you leapfrog to about 2015, in some diseases, you could say from 2010 onwards, it's changed very dramatically. And radiosurgery is now the workhorse of brain metastasis treatment, in addition to systemic therapy. We increasingly have moved away from thinking about the number of lesions rather than the volume and maybe the pattern of the disease to decide whether radiosurgery is the right treatment or not. Surgery is used for more than one lesion. It's really a question of what's the role of surgery in helping to keep this patient well while we're trying to get overall control of their brain disease. And radiation, I have not called whole brain radiotherapy anymore, because we do use other options, for example, just treating the posterior fossa rather than the whole brain, if we think it's appropriate to deal with the disease that's apparent at the time. If we move on to diseases where there's a very active systemic agent, melanoma being the most impressive, systemic therapy becomes one of the dominant treatments. Whole brain or regional radiotherapy becomes a small part of the treatment. And it's a sort of an interplay between radiosurgery and systemic therapy primarily, especially in melanoma, but to some extent in these other diseases. EGFR mutant lung cancer has very rapid and impressive durable responses in the brain as well from drugs such as osimertinib. Casting back to breast cancer, hasn't really changed that much in terms of systemic therapies just yet. And it's always worth remembering that the way that the 3 broad phenotypes behave in the brain is very different one from the other. Triple negative is very explosive in the brain. It's generally chemo resistant if patients have got metastatic disease in the brain, unless they're de novo presentation, of course. So they don't tend to do well with systemic therapy. They'll respond quickly to radiation, but unfortunately often don't have a durable response to that radiation. And as I mentioned before, they'll recur quickly after surgery in the main. So very short median survival. HER2 positive disease, we have these patients who are doing extremely well. They're often clinically very well with good disease control outside the brain or options for that. And it's about how can we control the disease in the brain for as long as possible with the least harm. Luminal disease, because there are so many patients with luminal disease, it's still probably the dominant population of patients with brain metastases from breast cancer. But oftentimes they have quite extensive meningeal disease. And so there hasn't been a lot of change in how we think about that in recent times, to be honest. I'm not going to talk about systemic therapies in great detail. There are many others in the medical oncology team here who are much more knowledgeable than I about the systemic agents. But my pragmatic thinking about it is that in the HER2 space, there has been some interest in older drugs, lapatinib disappointing really and more toxic. The TDM1 studies looking at metastatic disease and patients happen to have brain metastases rather than studies of brain metastases showed some activity in the brain, but not brilliant. Only about a quarter of patients had truly a response or even a clinical benefit, which is this at least stable disease up to 6 months. And then tucatinib is the newest one that's being studied, and there, through the HER2 CLIMB study, there was definite evidence of response in some patients and clinical benefit. So that's being studied now in combination with TDM1 rather than Herceptin. Unfortunately, the CDK4/6 inhibitors, such as abemaciclib, which in a rat or a mouse has good concentrations in the brain, hasn't translated into responses that we might see with other targeted agents, such as the BRAF inhibitors, with only very low response rates. So there's a lot of work to be done in that space. And in studies, sort of broad spectrum use of immunotherapy in triple negative breast cancer, again, not fantastic responses in the brain at this point, but perhaps better patient selection around the PD-L1 status and other factors may help improve that. And of course, this integration of immunotherapy with radiosurgery is a space that's not really been explored, but does offer opportunities for triple negative patients. So just talking about melanoma for a bit, we've got the ABC study, which many in the audience will probably be aware is an Australian study that was one of the first studies to demonstrate the role of ipilimumab and nivolumab in melanoma brain metastases. It was a study both of asymptomatic patients and symptomatic patients, and it became apparent quite quickly that symptomatic patients didn't do very well. And so they are not, sorry, this is data from the 5-year follow-up of the different regimens, but the asymptomatic patients didn't do very well, and it's not a good treatment. Sorry, the symptomatic patients didn't do very well, and it's not a good treatment for symptomatic patients. But asymptomatic patients, who are often picked up because brain imaging, brain screening is used in melanoma because it's so common for people to have metastatic disease in the brain, can give really extraordinary results when you think about it. 5 years ago or 10 years ago over at the old building, we'd be in MDMs about melanoma brain metastasis patients, and all the patients would be dead within 3 to 6 months, pretty much. Nowadays, with this combination, at 5 years, half of them are alive. It's just an incredible change in a short space of time. But unfortunately, as you can see, the intracranial progression is a bit below 50%. So still at least half the patients are needing more than just the ipi-nivo. There's an American study recently published their 36-month results, which show similar findings. So here's some examples of what you can achieve with the combination. This big horrible cystic thing, the multidisciplinary meeting, it was discussed because there had been a plan for surgery, and some of us argued against surgery as the first treatment because of the high risk of neurologic deficit and also seeding of tumour into the CSF. And so we said, let's try with radiosurgery, getting onto ipi-nivo first, and if we fail, then we can move to surgery. And he had a very profound response. You can see within 4 months, the lesions almost entirely disappeared. Here's another gentleman who didn't really have surgery as an option because he had both temporal lobes involved with disease. It's very morbid to resect both of those at the same time. And he had 5 lesions, in fact. So he had radiosurgery and immunotherapy. This was in April. By August, he'd had a very good response, but you can see there's still something there. And unfortunately, in November, he then had bilateral hemorrhages with quite significant consequence to his memory and cognition as a result of that. He's had one of them resected in an attempt to give him a little bit of time, but it's a pretty palliative situation. So that last result notwithstanding, what can we do to try to improve the outcome for asymptomatic patients who are on ipi-nivo? And so the follow-on study from the ABC study is the ABC-X study, specifically asking if we add radiosurgery to immunotherapy, can we improve the neurologic specific death rate at 1 year? I won't go into the details of how the trial's designed, but it's essentially randomizing patients who are on ipi-nivo to have all their brain metastases treated with radiosurgery or not. And just another example of how immunotherapy and radiation can interact in a melanoma patient to give quite striking results. This is the opposite situation. So this was November 2016, a long time ago. This guy had this lesion growing whilst he was on having a break from Pembro. He was put back on, because he couldn't have, sorry, he was on ipi-nivo, didn't tolerate the two, had a break, was put back on ipi, and we treated it. And then he's had 2 years later, complete resolution of the disease without even an inflammatory response there. So there's quite a lot we need to learn to understand why we can get these different responses in the brain when you combine the two. Changing tack now just to the other topic of interest in new things that are happening is cavity radiosurgery rather than whole brain radiotherapy after an operation. And this, as an idea, has really had very rapid uptake in clinic. There were publications in 2017, really very early studies, one demonstrating that quality of life was improved and survival was not affected if you used cavity radiosurgery rather than whole brain radiotherapy, and the other demonstrating that if you did surgery or surgery alone or surgery followed by cavity radiosurgery, the cavity radiosurgery essentially gave you the same disease control results as whole brain radiotherapy. So they're not as good as we'd like to see, only an 80% freedom from local failure in the cavity, but the same as whole brain and less toxic, hence the shift to being used in clinic quite quickly. The difference from whole brain is that there's obviously a higher failure rate elsewhere in the brain because you're not irradiating that, but we know from lots of studies of whole brain radiotherapy that this won't affect the patient's survival. It just might mean they need more treatment at a later date. And the main concern about the cavity radiosurgery practice is that there's this implication that there's a higher failure in the leptomeninges, because if there is any operative spill, it's very small volume, it's obviously asymptomatic. I mean, it's occult on the scans, but the whole brain must be enough to control that in many patients, because there is sort of retrospective and some phase 2 evidence that leptomeningeal disease failure around the cavity occurs after cavity radiosurgery that doesn't after whole brain. There are some other unknowns. The radiology can be really hard when you're trying to decide where am I going to put my cavity radiosurgery volume, and nobody knows what's the right volume. So some examples here. So this is the pre-op lesion. On the planning CT, you can see there's a little bit of a cavity there, but on the post-op MR, there's blood now down here. Now, do we need to cover that blood? For certain diseases, we know we do. Melanoma will carry that disease quite readily in the hemorrhage. Renal cell, it will. Breast cancer, probably it will. So you can see this is a much bigger volume than this was, and it's an unclear target. There's another question about margins. Do we need to treat normal brain around the cavity? Because in radiosurgery, normally we're minimising our dose to the normal brain around the cavity, but we're not needing to treat the cavity, we're needing to treat the edge of the cavity, which is where there might be residual disease. So that's an area of debate. And also, what's the optimal timing? There's emerging evidence that if you can do it within 4 weeks of surgery, that seems to give optimal results. And here's just an example of some of this leptomeningeal failure that can occur. This gentleman had this big metastasis from an esophageal carcinoma resected. His early post-op scan, you can see there was a lot of blood and hemorrhage and so forth. We let it settle down a little bit, and then he had 30 gray and 5 fractions, so a big dose. It's a yellow line that maybe you can't see beyond the blue line, which was the dose. That worked well around the cavity. There was no recurrence, but within about 5-6 months of his treatment, he had all this nodular disease around the base of skull, which was all leptomeningeal disease. And that was very difficult to control, and he died from that. So here's just an example of one of the publications showing that if they had treated, sorry, this is going to shift me now to preoperative radiosurgery, apologies, but this group are looking at giving the radiosurgery prior to the surgery rather than afterwards. And the rationale, as I said, is that this leptomeningeal failure after cavity radiosurgery is an emerging concern. The numbers are pretty variable, as you can see here, because these are just series from different departments, but happening in a way that we see clinically that we don't after whole brain. So there's no doubt it's a real thing. And this is an example of treating the cavity after surgery versus treating the lesion before surgery. And this is the rate of leptomeningeal failure. And you can see there's a difference there in that particular series, still being investigated. Further work in this area has shown that the people who are most at risk of cavity failure, leptomeningeal seeding after radiosurgery, have larger tumours, particularly cystic ones that they can spill. They're often hemorrhagic and cystic, as I said. If you can't get a single clean resection, it's sort of obvious, it can leave tumour behind. Contact with the dura, and breast histology is commonly a problem. And I think that's probably because we see a lot of leptomeningeal spread in breast cancer that may not be apparent on imaging at the time of the operation. So a few different groups have published here. You can see this is breast, colon, lung, melanoma, and breast is the dominant one for this leptomeningeal seeding. Similar sorts of findings in other departments. So the rationale then to move to pre-op radiosurgery is that you can define the target volume much more readily. The lesion is discrete on the MRI, tends to be smaller, not always, but tends to be. The theory is that you can sterilise the lesion, the periphery of the lesion, before the surgeon does the operation, so it's less likely that any seeding will survive and grow to be leptomeningeal disease. There's another theory that we can reduce toxicity from a few matters, a smaller volume, a well-oxygenated brain rather than an unwell-oxygenated brain, good for healing and good for tumour kill. And because you're treating a lower volume and potentially a lower dose, there's a theoretical risk you can reduce radionecrosis. And the other thing is, if it can be well organised, it's generally that the overall treatment time is shorter, because you'll make a plan with the neurosurgeon to do the radiosurgery, have the operation, whereas the other way around, the surgeon does the operation, might think about referring it to the radiation oncologist, and time can pass, and there might even be a month before the patients refer, let alone receive their treatment. But the risks, if you give radiosurgery before surgery and the lesion has already got mass effect, the lady with the cystic metastasis that I talked about at the beginning only had mild mass effect, but potentially if you induce more mass effect, you might make the patient more symptomatic. And certainly in the posterior fossa, it might be dangerous to do it before surgery. So this is a discussion that has to be had in the decision-making process. There are some concerns about post-op wound healing being poorer. In practice, I think that's not going to be a major issue because the skin dose is very, very low. And if by chance you've got a patient whose diagnosis is not known, I mean, as a general rule, you wouldn't do radiosurgery prior, but there might be a situation where it arose and it may be that it's not malignant, or maybe it's a different diagnosis like glioblastoma, for example. So what we're doing in the neuro group, we've got an interest in pre-op radiosurgery in particular, and Joe Sear, who's joined us after his PhD in the lab in immunoradiotherapy combination, is the lead on this. Really, at the moment, it's just a feasibility study to see if we can get this to work, because we've been trying to get traction around pre-op radiosurgery with our neurosurgical colleagues, and they're very interested, but it is hard to get it to happen in practice. So we don't want to open a bigger trial until we know that we've got the systems working properly. This particular study is only for lung and melanoma patients because they are the ones who often need both surgery and radiosurgery. And the questions that Joe wants to look at are about the immune effects of the radiosurgery on the brain metastasis and the brain milieu. So they're the ones that are very immunogenic because of all the genetic abnormalities in non-small cell lung cancer and melanoma. So it's just a pragmatic choice to use those two at the moment. The idea is that the patient will be consented to the study, have their radiosurgery before their surgery, at least 7 days after their radiosurgery, but not more than a month later, they'll have the metastasis resected. And then Joe's going to look at a whole lot of different parameters around immune status and response, of which there's very little information in the literature. If we can get this system to work, then we can broaden it to a whole lot of other clinical questions. And that's what the brain pop is about, perioperative work in brain disease. So summing it up, brain metastases remain a very key challenge in metastatic cancer. There have been some amazing changes in the last 10 years in particular, primarily related to the systemic therapy changes, but also because of improved technology. We've really had this dramatic shift away from whole brain radiotherapy, which is improving patients' quality of life without affecting their survival. So that's a good outcome. The irony of all this success with systemic therapies is we have these new populations of people who have brain metastases now, who never used to have brain metastases, but that's because they're living longer. Prostate cancer is probably the most extreme example. And in particular, we have this growing population who have chronic brain metastases, a population of patients for whom the kind of radiosurgery is not a very nice treatment for the brain, really, and radionecrosis, which I haven't discussed today, is a very common problem that we see now that we're going to have to resolve if we're going to help people to have good quality of life and live with controlled brain disease. And I think the future lies in this better understanding of what's happening in the brain. Why, for example, does abemaciclib get into the brain but not induce responses? These sorts of questions people have been thinking about for a long time, of course. And hopefully things like our PRISM study with pre-op or perioperative analysis of drug behaviour or radiation behaviour will help us to understand that over time. And I remain convinced that when we're designing clinical trials, we also need to really emphasise what's the optimal integration of all of our different active therapies in the patient's pathway to make sure we get the best results of or the best outcomes for the patients, but also that the trial is designed in a way to give us the most useful information. And that's all I've got to say. Thank you very much. And I'm going to stop sharing.
So thank you so much, Claire. Fantastic talk. And it's just so wonderful to see the evolution of this treatment. I too remember the days as a registrar and being told that everybody who had brain metastases was just going to get whole brain radiotherapy and die in 3 months. And it astounds me constantly to see what's happening. So we do have some questions. The first question is from Bruce, and he has a question about intrathecal therapy and what's its status. I'm assuming it's intrathecal systemic therapy, and what its status is now in the context of SRS and gamma knife and all these new technologies.
Yeah. So, intrathecal is primarily used for leptomeningeal disease. And I'd say that its status is unchanged for a long time. The most interesting area has been in using HER2 agents in the intrathecal space. But I think mostly related to governance and practical issues. Those trials have been very difficult to get up and running and have not really progressed in any way, shape or form, really for more than 5 years. And then there's been a little bit of interest in radionuclides in the leptomeningeal space as perhaps a different way of trying to get active therapies. But the problem with those is that they have very, very shallow depth of activity, and the leptomeningeal disease is often thicker, essentially, than the alpha or the omega electrons or whatever it is that are being used can actually penetrate. And really no other change. But in terms of the relationship with what we're doing, so they're really different populations. Radiosurgery remains very much for local discrete problems, and intrathecal therapy is very much for leptomeningeal global neuraxis problems.
Do you ever do both? If you see some, or is it just that the leptomeningeal disease has such a poor prognosis it overrides what's going on in the parenchyma?
We often see what we call local leptomeningeal disease. So a lesion where we can see, in the post-fossil with HER2 disease is the simplest example. You can see the disease and it's sort of tracking along the folia of the cerebellum, and it's slightly linear in shape. And you know that you can encompass it in a radiosurgery volume, and there's really not much else to see. So we will treat that with radiosurgery, but we do know that it's not the optimal kind of lesion, that local failure will be more likely because it's probably more extensive disease than we can see. And it also, less with the gamma knife because it's so tiny, the fields that we can treat. With the P6, it used to be hard to get a field that shaped nicely around it without risk of harm to the adjacent brain. If they're really long and skinny, it's not that easy to treat.
So we just have another question about, now that, of course, we're seeing so much innovation and development and prolongation of survival with SRS, what should we be doing for asymptomatic patients with brain mets? You know, how closely should we be monitoring them?
Yeah, I think it really comes down to the disease. Yeah, so unfortunately, in HER2, for example, there's been discussions for a long time about should we be surveilling people with metastatic disease for brain metastases so we might pick them up earlier. The problems with that are a few. The main problem is that although many, many patients do get metastatic disease in their brain, the duration that they've been on their systemic therapy before they get it ranges quite widely. So if you're doing a scan every 3 months for these women for 3 years before they get the metastatic disease, that's a lot of scans, that's a lot of scanxiety. And it won't, the other underpinning thing I think is that we haven't, despite, apart from whole brain just stopping a person from dying, radiosurgery doesn't really keep somebody alive for longer. It's really the systemic agents that are doing the keeping people alive for longer, as long as we can control the brain disease. And we haven't got evidence yet that picking it up earlier is going to help the patient live for longer. It's tricky because you see it there and you think, oh, we better treat it. And you might just introduce harm in the form of radionecrosis. So in other diseases, melanoma, as I said, it's so likely, something like 70 or 80% of them will get metastatic disease in the brain, either at presentation with their metastatic disease or within the first year. But regular scanning is a very efficient thing to do, and they also grow very fast. So you want to get onto them quickly. But there are plenty of patients who've got known metastatic disease who still turn up with clinically symptomatic disease that's grown between scans.
So I have a question from Keelan about treating pregnant patients with brain mets and whether it's advantageous to do gamma knife versus LINAC-based SRS because of the scatter.
Look, I don't know the details of the scatter in the sense that we haven't had to deal with it yet. I could imagine one of the advantages would be that, beam angles, if you think about LINAC beams coming more broadly through the patient, there's certainly more opportunity for scatter into the body, and the energies are higher. So for those reasons, I think on theoretical grounds, you would expect there is more scatter. To be honest, the uterus is a long way from the brain in terms of radiation dose. And if a woman's got brain metastases and pregnant, I suspect treating with either modality is better than not treating if she really needs the treatment, and the risk to the fetus will be very small.
And then somebody's just asked if in a nutshell you could summarize in a couple of lines who the ideal breast cancer patients are for gamma knife, if they're referring particularly from outside.
Well, I think from outside, the ones that it's very efficient for is multi-metastases. Like, so if you're from a department that is doing radiosurgery on a LINAC, I think the tipping point is about 4 lesions. It's just so quick and easy to treat multiple lesions in a short space of time, and much easier to get the planning done. There's no QA physics of any complexity required. For me, that's the tipping point. If you're giving SRS to 1 to 4 lesions in your LINAC at your home department, very reasonable, and keep doing that.
And in terms of the workup for those patients, if they're being referred, say, from the country, I mean, obviously you need to have a baseline MRI, but what do you tell the patient about what to expect when they come in?
Yeah, well, thanks to the wonders of telehealth, we can do a lot of it, on a telehealth consult to start off with. So if the referring rad-onc, usually a rad-onc, sometimes a med-onc from departments that are used to referring patients to us, tells us they've got a patient with brain mets, we'll look online at their scan just to make sure that we think that they're suitable, and then we'll do a telehealth consult. And really, it's very simple. We explain to them that on the day they'll come, we'll make them the mask, we'll do the MR, we'll do the planning as I described. Obviously, we spend a bit more time than that, but I won't go into the detail now. And then, what else? They can't drive themselves, as we know. They'll probably have a bit of sedation. If the treatment time is long, it's easier for the patient to get through it if they have a bit of lorazepam and somebody else needs to drive them home. We talk to them about whether they prefer to have one big long day or come and have measurements and come back another day. There are some practicalities around what suits the patient best.
I have a question about stopping or continuing systemic therapies with SRS, because my feeling is that you get less edema than you do with whole brain radiotherapy. But what's your sort of policy around that?
I think it's more about just how much brain tissue is actually being irradiated. It's not very much to any meaningful dose, but it also depends on what the systemic agent is. So I really don't like taxanes and radiation together because we know that taxanes are neurotoxic. But immunotherapy has got a very long half-life, so it doesn't really make sense to stop taking immunotherapy, and probably you get more efficacy from a combination anyway. There was concern with the BRAF inhibitors early on that we shouldn't use them simultaneously. But a lot of the toxicity from the combination comes from what I call wide field radiation, like skin toxicity and things that just aren't an issue in radiosurgery because the skin dose is so small. Brand new drugs like CDK4/6 inhibitors, you can usually work around the agent, the dosing, and when we don't really know what the toxicities are, we prefer not to put them together. But it does depend on the clinical situation and the drug.
I think that's all. It's it was a great talk, and everybody's enjoyed it tremendously. So everybody's saying it's a great talk. So
My pleasure.
Thank you.
Take care, everybody.
That's okay. So that's the end of today's webinar. And so I'd like to thank Claire and everybody who's online for tuning in. And just a reminder that the recording is available if you want to look it up, and you can pick that up through the VCCC Alliance Open Learning page. Thank you all very much. Thanks.